Good afternoon and welcome to today's program. It's titled Treatment Centers and the Healthcare Reform Act. I'm Dennis Grantham, Editor-in-Chief of Behavioral Healthcare Magazine. Today's program is sponsored by BRM Network. Thanks very much to our sponsor and to all of you in the audience for giving us your time and attention. Before we get started, let me just run through a few quick housekeeping details. Each window on your screen can be moved by clicking and dragging it, or enlarged or minimized by clicking the icons in the top right corner of each window. Please use the Q&A area to the right of the slides to submit a question at any time. If you can't see the Q&A area on your screen, just click the red Q&A button and it will appear. To download a copy of today's slides, please click the link in the Resources area in the bottom left of your screen. If you have any technical issues during the program, please click the yellow Help button to troubleshoot the issue with our technical team. For those seeking certificates today, they will be distributed using the green Certificate of Participation button at the end of today's program. At the end of the program, we will give you further instructions on how to print those out, so please hold on at the end of today's event. You can also tweet during today's presentation via the Twitter widget. Just click on the blue Twitter icon at the bottom of the screen. Simply click Post and click those buttons to log into your Twitter account and begin sharing at the hashtag BHReformAct. At this time, it's my pleasure to introduce our speaker, Bruce Rosenberg, Esquire, who's a partner at the Florida Healthcare Law Firm. Thank you, Bruce, for taking the time to speak with us today. And with that, the audience is yours.
Thank you, Dennis. Good afternoon. First, I'd like to welcome you and say that I hope that I'm able to communicate some interesting and useful information to you about the Affordable Care Act. The overall slides and presentation were actually initially created specifically for a general overview of the Act, and I know that you will probably be more interested in directly what affects the area of substance use disorder and mental health provisions of the law, and I want to speak about that a little bit off of the chain of slides, and so I might be jumping around a little bit because I don't necessarily think that the substance of what's important here needs to be read or gone through by virtue of the general nature of the Act itself. But, to start with, there's always been an understanding or a belief, which I think is accurate, that mental health is sort of the undiscussed or neglected area of healthcare. And in fact, if I could see a show of hands, only kidding, if anybody read the USA Today this morning, one of the headline articles is that there's a healthcare crisis looming for seniors. And in this article, interestingly enough, it quotes that 1 in 8 Americans are now 65 or older and projected to grow to 1 in 5 by 2030. It talks about the nearly 8 in 10 seniors living with one chronic health condition, referring to obesity, diabetes, arthritis. And interestingly enough, the article does not discuss mental health or substance abuse. And the Affordable Care Act was created and put in place in order to bring certain cost savings efficiencies to the healthcare industry, as well as to provide expanded care and availability and access to care to a large group of citizens and patients that just simply haven't had the ability or the coverage to get it. Now, most recently, the White House chimed in on the mental health aspects of the act, and Secretary Kathleen Sebelius noted that we're still in a country that too often confines mental health and addiction to the far edges of our discourse. Cannot ignore the fact that 60% of people with mental health conditions and nearly 90% of people with substance use disorders don't receive the care they need. So from a perspective of the Affordable Care Act, the White House really wants to see more emphasis and more focus on providing services in overall health care to mental health and substance abuse. They project in fiscal year 2014, the president's budget includes $205 million investment in programs to help identify mental health concerns early and improve access to mental health services, as well as support safer school environments. There are going to be initiatives to help teachers and other adults identify early signs of mental health problems and refer young people to services they may need, and to advance new state-based strategies to prevent young people between the ages of 16 and 25 with mental health or substance abuse problems from falling through the cracks when they leave home. That being said, the Affordable Care Act includes substance use disorders as one of the 10 elements of essential health benefits. And what that means is that all health insurance sold on health insurance exchanges or provided by Medicaid to certain newly eligible adults starting in 2014 must, let me emphasize, must include services for substance use disorders. All right? Now, by including these benefits in the health insurance packages, more healthcare providers can offer and be reimbursed, and that's essential, or at least it appears to be a carrot, to be reimbursed for these services, resulting in more people having access to treatment. But there's still a limitation on that, because not every service is going to be covered, and there's still going to have to be a list put out and debated as to what will or will not be covered. So if we can skip now, or we look at the first slide, we're talking about the key features. One, the Act is supposed to improve quality and efficiency of health care. Two, it's supposed to reform the health insurance market. Three, it's supposed to expand public programs. It's intended to not only treat but prevent chronic disease and improve the public health. It's supposed to support and regulate the healthcare workforce. It's supposed to provide for transparency, and that's a big one there. What is transparency? I believe that means scrutiny. It means the ability for the government and other regulators to review and audit what the providers are doing as well as what their billing processes are. And the last one but not least are the revenue provisions, which are intended to promote a better compensation and bonuses for providing more effective and efficient healthcare services, as well as potentially have penalties for those providers that do not achieve the goals that are set forth in improving the provision and delivery of healthcare services. Now, I believe it was Thomas McClellan, the co-founder of the Treatment and Research Institute, who described that substance abuse under the ACA will also become part of primary care and will be focused more on prevention. Essential services will have to be provided by health plans, and they have to treat the full spectrum of the disorders, including people who are in the early stages of substance abuse. There's going to be more prevention, early intervention, and treatment options. Now, interestingly enough, what happens here is that the Act is going to provide two major changes. One, it's going to create a tremendous increase in the number of insured patients, which is going to in turn create the need for additional treatment, as well as with that treatment, there's going to be additional reimbursements. Now, with the benefits, there are burdens, and one of the things the government is looking to do is going to be to reduce the cost to the government of the healthcare being provided, but also key to those providers and treatment centers dealing with substance use disorder and mental health. You're going to have to continue to look to cut costs and to avoid financial risk that comes along with the additional regulation. So along with the patients that you're going to get and the potential business, you're also going to be affected by parts of the Act, including the HITECH Act, which actually brings into play electronic medical records and interface. There are going to be additional costs to you in doing business, additional scrutiny. And within that, we have to understand that with the benefits, there also are going to come additional burdens. So what I wanted to do first is sort of skip down to one of the later slides, which is number 50. If I can get there, I'm going to try to do that real quick. And slide number 50 is going to lay out or present the part of the presentation talking about substance abuse disorder and mental health. Now, please understand that the slides and the rest of the presentation is available to you. If you have any questions, you can email us. You can let us know, and I'll be touching upon the General Act a little later. But really, I think these are the most essential parts of the changes in the Act. First, substance use disorder and mental health services are going to be contained in basic benefit packages. Second, there's going to be a requirement that all plans in the health insurance exchange adhere to the provisions of the Wellstone-Dominici Parity Act. That means that mental health issues and substance use issues are not going to be second-seated to general health care. Now, to that effect, I wanted to read to you a little bit or talk to you a little bit about what the Mental Health Parity and Addiction Act, Equity Act of 2008 is. And that was originally created to speak to the treatment and limitations that were being imposed on patients with mental health and substance use disorder problems and the benefits that were being restricted by the healthcare insurers in the industry when compared to medical and surgical benefits. And the point of the Mental Health Parity and Addiction Equity Act was to say mental health and disorder and substance disorder problems are one and the same and equal to general health care, because for all these people that were mentioned in USA Today that are having these chronic problems, a great percentage of them, of the old as well as the young, are affected and need mental health care and or substance abuse counseling and care. And given the effect of the Act, and I'm sorry, just give me a second. I'm going to change the slide once again to the next slide, which is, I believe, 51. All right. The new law is going to look to prevention initiatives for substance use disorder and other mental health issues. And it's going to look for the workforce in these areas to develop new initiatives to fit in and to correlate with general health care. Now, the way that a lot of people perceive this and look at it is that you're going to have the medical providers integrating mental health care into their practices, but really, as part of the mental health and treatment center's perspective, it's how do you integrate or work with or get involved with additional treatment in a general manner that will provide for the overall care and treatment of people who need substance use disorder help and or mental health care. And in doing that, you probably, looking to expand your structures and your businesses to reduce your costs and to avoid risk, may reach out into areas such as analyzing and toxicology, urine analysis, and those are good platforms to be looking for, but they can be very expensive and again incorporated into your business, as well as psychiatric and medical. Previously, patients were rarely ever compensated in any way by the state or federal health care program to receive or to obtain these benefits. Now there appears to be the opening of a way to have less issue with getting reimbursement and more ability to provide for the patient's needs. As I mentioned earlier, or let's go back to the slide for a minute, there is in the new law provisions for coverage for substance use disorder prevention, treatment, and mental health services to be eligible for community health team grants aimed at supporting medical homes. So with this integration, there's going to be more of an opportunity for providers of these treatments and of these needs to obtain more reimbursement, but that also will bring more scrutiny, as I suggested earlier. And we already are all aware of the requirements that have been set out by the HIPAA law with regard to privacy, and the False Claims Act, and the Stark law, the anti-kickback law, and those laws also come into play and into perspective when you start to reach out to market and to deal with building your facilities. You have to be very careful when you expand, and when you do that, you need to really look at the law, and you need to have a review of the law and a good healthcare attorney to help you work through those issues as far as structure and relationships and billing, because what the government refers to as transparency back in slide, I believe, number 6 or 7, really means they want you to increase the use and refine your compliance plans, written compliance plans on everything from patient protocols dealing with the patients, HIPAA, privacy, professional practice protocols, and especially billing protocols. Because under this act, and given the fact that we're going to have more and more treatment to patients who are receiving Medicare benefits, one of the liabilities that comes along with that is audit and review by CMS, the Centers for Medicaid Services, of both your practice protocols and your billing protocols. And that can lead to problems, a domino effect of audits and issues with regard to False Claims Act problems. Now, when I say False Claims Act problems, which really aren't part of directly of the Affordable Care Act, you're looking at a scenario where marketing and providing scholarships, as you may have done or do in the past, can easily and rapidly become an issue within the Act. And the reason for that is that under the False Claims Act, there is a strict limitation on the value of gifts that can be given in relation to either patients, referral of patients to patients, or accepted from others with regard to the treatment of patients. And currently the rule is actually any one gift cannot have a monetary value of more than $30, and over the course of a year, totality of gifts for any one provider or entity can only be $350. And that goes from everything from bonuses to staff to literally meals being provided or marketing by pharmaceutical companies. You have to be very careful. In fact, most recently, there was a False Claims Act case brought by the government against a major pharmaceutical company because they were paying for providers allegedly to give presentations at lunches at restaurants, very famous restaurants, and or golfing outings, and they were giving a check to the doctor, the provider, to give the speech to one or two people. And the government said this was not appropriate, and this was actually a form of a kickback, and that there was going to be recourse under the Whistleblower Act based on the fact that these doctors were paid a nominal amount of, let's say, $1,000 to give these presentations, and that gave extreme liability exposure to the doctors, because something as simple as an agreement for marketing can subject you to exposure for disciplinary, administrative, civil, and or criminal proceedings concerning the amount of the gifts and the circumstances. For instance, with pharmaceutical, with a situation that happened most recently, which I'll share with you, there was a false claims action initiated by a whistleblower who worked for a home health care service. And the whistleblower said that the facility or the service that was receiving the referrals from the providers for purposes of receiving the needed healthcare services, even though they were not receiving a direct payment by the home healthcare service, the home healthcare service had in fact turned around and entered into, quote, employment agreements for marketing with the provider's relatives, including several wives and other close relatives, where basically they were in form legally contracted as employees of the home health care service who were doing marketing, but really in substance it was a sham, and both the providers and their wives are not only subjected to civil liability under the False Claims Act, but also potentially criminal prosecution for violation of the False Claims Act, because the False Claims Act provides that you cannot submit a bill for any service, not only healthcare services, but any service to the government which is false or is the result of medically unnecessary provision of medically unnecessary goods or services, and or based upon the illegal kickback or referral schemes which can happen when you get involved in cross-referral agreements and or even practice management agreements. So the fact that the Act is opening up a world of new patients and the possibility to earn greater income brings with it additional costs, which are going to be the creation of compliance plans which ensure an auditing and the correct provision of services, as well as the costs potentially of electronic health records and integrating the records and the availability of the records in electronic form to other providers that are also caring for your patients. So I think that you should understand that although there may be a great increase in the number of patients that are available for treatment, there's really going to have to be some focus on how you can expand your business and not be impacted in a negative way by increased costs, by increased regulation. Now I'd like to go back to the beginning and talk about the Affordable Care Act in general. And so I'm going to go back to slide number 5 or 6, if you give me a second. And we'll review what the basic part of the Act is. And this is not specifically directed to the mental health and substance abuse part of the Act, but this is just the Act itself. The point of the Act is to improve quality and efficiency of health care. There's going to be a linking of payment to the quality of the outcome. The Act encourages development of new patient care models, which are ACOs, I'm sure you know what they are. I apologize, bundled payment models, medical homes. There's also going to be a new focus on the use of electronic health records and related technology, and they're going to look to fill the donut hole of Medicare Part D, which is costing great amounts of money to people who are obtaining benefits from Medicare. It's also going to create a Medicare advisory board. When we talk about linking payment to quality outcomes, there are going to be a couple of different programs. There's going to be the value-based program for hospitals, which was starting in 2013, and it's going to link payment to the quality performance on certain high-cost conditions such as cardiac, surgical, and pneumonia care. It's going to look at long-term care hospitals, inpatient rehabilitation facilities, and hospice providers, all participating in value-based purchasing programs. Providers who do not participate in a value-based purchasing program will be penalized. The Act wants to encourage development of new patient care models. The government wants you to take responsibility for the cost and quality received by the patients, and you will share in the savings that you achieve for Medicare. Medicare is looking to bundle payments for care, and there's a national voluntary program to encourage providers to improve patient care and achieve savings through bundled payments. There's going to be creation of medical homes. That is where the patient is. hospital payments will be adjusted based upon the quantity of potentially preventable Medicare readmissions. So they're going to look to benchmark the care that's being given. All right, and now accountable care organizations, which are different from the Medicare Advantage plans, are going to allow providers who voluntarily agree to work together to coordinate care for patients and that meet certain quality standards to share in any savings they achieve for the Medicare program. These accountable care organizations can elect to become accountable for shared losses, and they will have and if they do agree, if you're part of an ACO that agrees to be accountable for shared losses, then you're going to have an opportunity to share in the greater savings, to get a bigger bonus. The ACOs will coordinate and integrate Medicare services with success being gauged by roughly 30 quality measures organized into 4 domains: patient experience, care coordination, patient safety, preventive health, and at-risk populations. The services related to substance use disorder, and mental health are yet to be fully determined, but there have been some, I believe, essential health benefits articles written, discussed about what the mental health essential services are going to be. I believe you're looking at inpatient hospital services for mental health in accredited institutions, routine outpatient mental health and substance use services, which would be furnished by a licensed practitioner, including psychotherapy and medication management, including management of adverse side effects. The plans are going to have to comply with the Federal Parity Regulations, as I've stated earlier. Psychotropic and addiction medications, psychiatric rehabilitation services, screening for suicide ideation in depressed patients, patient and family education and self-management, intensive case management, and at least one service designed to avoid institutional placement for chronic and serious mental disorders, both for children and adults, in order to ensure a sustainable, successful outcome, stability, or remission of a serious or chronic condition, and peer support services. That's the mental health and the substance abuse aspects of the program. Now, as I said, there is a significant difference between the ACOs and Medicare Advantage plans. The ACOs are part of a traditional fee-for-service program, and the fee-for-service that they get is going to be based on benchmarking and the productivity and cost savings and efficiency that those organizations provide. Now, even if there is an ACO, the beneficiaries are still free to see any provider they choose, and the organization cannot require the beneficiary to only get treatment from other providers who are within the ACO. There will be an assignment of beneficiaries to ACOs. There's going to be a 2-step process. All right. The beneficiary is assigned to an ACO if the beneficiary receives a plurality of his or her primary care services from primary care physicians within the ACO. Primary care physicians are defined as those with one of 4 specialty designations: internal medicine, general practice, family practice, and geriatric practice. It should be noted that glaringly lacking from that list are providers of mental health treatment and substance abuse disorders. Let's move along down the line a little bit, because the ACOs and what they provide and what they get are pretty specific, and you can read about them. It's very dense, and I don't necessarily think it helps. But getting back to it, an ACO can choose from one of 2 program tracks. The first track allows the organization to operate on a shared savings-only arrangement for the duration of their first agreement, and the second track allows the ACO to share in savings and losses for the duration of the agreement in return for a higher share of any savings that it generates. Bundled payments for care improvement. This is a basis of fragmented as opposed to coordinated care. A single episode of care is often comprised of several fragmented treatment segments that are discretely reimbursed, e.g., and once again, all of these examples are of general medicine and not with regard to substance disorder or mental health considerations. Orthopedic surgery, at least diagnosis, imaging, surgery, hospitalization, anesthesia, pain management, physical therapy, and you could simply cut and paste into this slide the aspects of treatment for mental health disorders and substance abuse. Now, part of the bundling of packages for hospitals would involve inpatient stays, post-discharge services, and or post-discharge services only an inpatient stay. Now, when you apply this to substance use disorder and mental health, the same way, the Act should provide for an opening for treatment centers and providers of services in this area to create structures which enable both the treatment and reimbursement of multiple services bundled into one bill to monitor and treat and help the patient. And I think that's what Thomas McClellan was referring to, that the ACA substance abuse treatment should become part of primary care, and it should be focused on prevention, and that is an essential service. Winding down, I only have 1 or 2 minutes left, so I hope that I've been able to at least give you a general introduction. I can always provide you with further information if you need it. I hope that I made clear that the parity standard is very important, and I'll leave you on this. Providers and patients in substance use disorder and mental health areas should be treated as equal to general health care issues. Their needs should be part and parcel of general health care and preventive medicine, and the Act is going to create many opportunities, but also there are many pitfalls that may be avoided by using and consulting with either your boards or a very good healthcare attorney. Anyway, it's been my pleasure to speak with you today, and I hope that you've gained some information that you can use. If you need, I'm available. You can email me any questions and or contact me at the phone number provided. Thank you again, and now I'm going to turn the floor back.
I think you're going to turn to me. Hey, Bruce, thanks for diving into that information. Hey, you had mentioned that along with the expanded opportunities for treatment come expanded responsibilities for compliance. Can you outline a few of the 3 or 5 areas where people are going to have to re-examine their compliance policies or consider new policies with regard to the Affordable Care Act?
Certainly. When we talk about compliance plans in general, I think that we're more familiar, or most of us would be more familiar with HIPAA compliance plans with regard to patient information and assessment of risk of disclosure. Compliance plans under the Act refer to not only HIPAA compliance, but also billing fraud and practice protocols. So there is no set compliance plan, but each provider each and every provider and facility is required to have a written compliance plan under the Act. And that requirement also runs down in downstream to any direct employees or professionals underneath your business. I mean, it flows downward in tract, which means that you will, not only are you responsible for your own personal or specific practice protocols and billing protocols, you're also going to be held accountable and responsible to make sure that all those around you are also following appropriate procedures and have written compliance plans. And the written compliance plan should provide for designating specific people responsible for auditing and discovering problems and disclosing issues with either fraud or billing as in the most effective manner. In fact, one of the most important points of the new Act is that the compliance officer or the compliance part of the business needs to be able to speak directly to the CFO and not to be interfered with. And the CFO, as well as the people who are in charge of the businesses, must be involved in all areas of compliance, meaning practice protocols, billing protocols, record-keeping protocols, auditing, keeping up on the most recent guidance from the OIG, keeping up on the most recent literature with regard to treatment and care. So as the OIG has previously pointed out, is discretionary really. Each plan, you don't have to have the most complex and specific plan, but each provider, from a solo provider through the biggest business, is now going to have written policies, written plan on how to deal with preventing, detecting, and deterring fraud, as well as cost reduction and patient care that's effective and appropriate.
Okay. Well, thank you. Perhaps a clarification on the essential health benefits. I know you listed quite a few that were possible or potential benefits or suggested benefits. Now, isn't it correct that state by state, each state is determining its own essential health benefit plan from a series of choices that was provided by the government, right?
Yes.
From a large small business plan to some of the state or federal employee plans. So, okay, so that might be something that they, specific EHBs would vary by state then, and you could find out more. I know I just published a link a couple weeks ago in a story about where to find more on essential health benefits by state, but basically that's something you can look up.
Absolutely, and Dennis, not to cut you off, that exactly is one of the items that should be part of every compliance plan, a listing of those essential benefits.
Good idea. We're getting down to brass tacks. Bruce, do you foresee strict auditing for commercial payers, or is this just with government plans? I guess do these regulations on transparency and billing fraud, do they apply to commercial payers as well, or just to Medicare, Medicaid?
Well, what happens is the reality is that they are specific to Medicare and Medicaid, which is the most conservative type of review, and I would say it's the polar opposite of the most liberal. It's going to be the most strict and the most conservative. And in my experience, insurance carriers and private companies are always going to look to restrict and to pursue and follow the lead of DMS when it comes to auditing. So even though the contract might not provide initially for that type of scrutiny, I would believe that all insurance carriers and their SIU units are already looking to set the standard in the private arena that equally applicable to private contracts.
Sure.
Providers should have the same exact type of compliance program and transparency as under the CMS rules and under the ACA.
So if you can tackle the CMS rules, then you should be okay with commercial payers. Essentially, CMS is going to drive a new de facto standard on it, sounds like.
That would be the safest and best practice.
Okay. A question, where does whistleblower protection stand at this point in regards to enforcing parity compliance? Currently, without whistleblower protection, facilities won't bite the hand that feeds them, so parity can't be fully enforced. Is that something you're prepared to talk about, parity enforcement, or who's doing it?
As far as, all right, the False Claims Act, I'm not aware of any parity enforcement right now. I think that this is just the standard is coming to bear, but I think that there have to be teeth, there has to be a penalty involved, and I think that what you're going to have is when complaints are filed, I think you're going to end up with audits. You're going to end up with the full spectrum of possibilities of everything from administrative proceedings to criminal prosecution or failing to abide by the act. The government will go in and seek, if it's going to be, let's say, a large company or a hospital, they'll seek a corporate compliance and integrity agreement, and they're going to seek to make sure that the parity is part and parcel of every agreement that's going on.
Okay. Now, I know, if I may add, just from news that I've read lately and things that I've heard from where I sit, I know that the American Psychiatric Association has a considerable parity enforcement effort underway. I know there was a case that they recently won, or they were involved in the group that won the case in Connecticut, and it was against Anthem Blue Cross Blue Shield, and it had to do with manipulation of rate codes, or the way in which the codes were being read was apparently overly restrictive or arbitrary. In any event, I know that they do have an email that you can send parity enforcement complaints to. I heard from a spokesman at Mental Health America that they're also active in that effort. And at one time, there was a desire to get a bunch of really perfect cases together, perfect, spotless, bulletproof cases. And that's sort of given way to the idea of let's get as many specific complaints in as possible, and we'll react to those. And until the final parity regulations come out, of course, these organizations are trying to drive interpretation of the law in lieu of stronger regulations. So I just thought I'd add that in. Let's see, another question. Again, this has to go to credentials, I guess. Will government reimburse clinicians who are only certified substance abuse counselors versus master prepared clinicians? I don't know if you can address the issue of credentialing or not, but I might be able to offer a partial answer.
Well,
anything on that, Bruce?
I'll let you give the bigger part of it, but what I can say is that from a legal perspective, you should check with CMS as far as the coding and what's an appropriate bill or not before you submit a bill.
Sure. And I know that in general, the thinking is, since commercial insurers are going to be involved with a larger spectrum of the population, that commercial insurers do have the right to enforce their own credentialing requirements. So if you don't have specific credentials or have them at a certain level, you may not get the reimbursement that you expect. Now, traditionally, government programs have, I believe, been a little bit more liberal than some of the insurance companies in terms of making sure people get care. But certainly the issue of credentials does come up, and, in general, the requirements are rising. Let's see. Another question. how are SUD facilities expected to implement high-tech, EHRs perhaps, without regulation for Part 2 protection? Bruce, are you in the weeds on Part 2 protection? CFR 42 Part 2 and the relationship with EHRs?
I think that is a very good question, and I think that I can't give a specific answer to what the full effect of that is going to be, but I know that there is going to have to be a movement to the EMRs, and there's going to have to be a final determination made on how that Part 2 is going to affect it and how to deal with that. But I can't really speak to it other than that right now.
Mm-hmm. Well, I know from some recent reporting, I know that there are a couple of work groups, or at least a work group working on it in Washington, the Data Segmentation for Privacy group. They're experimenting with ways to code sections of the clinical document, or the CCD, specifically behavioral health or addiction treatment sections. And of course, addiction treatment is what's covered by 42 CFR. So they were looking at ways to use restricted coding, and those means appear to be effective in the pilots that they've had. However, when it comes to storing thousands and thousands of records and controlling them on a health insurance exchange, that is a considerably larger effort, given that the HIEs are really, by and large, developed to be HIPAA compliant. They weren't, by and large, developed with features that would accommodate CFR 42 Part 2. So it's my understanding that either the regulation of CFR 42 Part 2 will have to change to allow some redefinition of terms that the HIEs can allow and can work with to control the flow of those records, the sensitive records, or else what seems more likely right now is that users with sensitive information will have to sort of opt in to the HIE for all their information or opt out, which means, unfortunately, until there's a much, much better solution, addiction treatment records may well be sort of opted out of the health insurance exchanges. Of course, there are solutions using the NHIN, the so-called direct approach, and if you need a direct account, they can be had. Just look up NHIN Direct, and you can get an email account that is secured that you can use to exchange confidential information with other medical providers as allowed by CFR 42. But again, I think that's all I'll say about it. Let's see, another question. Let me. Let's see. There's some very. Let's see. Sorry, Jeff and Bruce, I'm struggling a little bit with the volume of questions here. Let me see. Currently, here's a question. Currently, parity requires that substance use disorders and mental health are covered at the same rate as medical, I'm not sure it's the same rate as medical conditions, but even though the benefit is there, does not mean that the individual patient will be allowed to use it. For example, the number of inpatient days allowed. I don't know if you can expand a little bit on where parity is right now, Bruce, with regard to maybe quantitative or non-quantitative treatment limitations. Are you prepared to talk about that today?
Well, I actually have, as part of the document I was using on the Mental Health Parity and Addiction Equity Act of 2008, I can point you to a statement or some information put out by the Department of Labor under the Employee Benefit Security Administration, and it discusses this parity standard for non-quantitative treatment. And I'll read you a quick quote from it. The parity standard for non-quantitative treatment limitations does not require applying a simple arithmetic test to compare the treatment of mental health or substance use disorder benefits to the treatment of medical surgical benefits.
Mm-hmm.
The Department interim rule provides that under the terms of the plan as written and in practice, any processes, strategies, evidentiary standards, or other factors used in applying the non-quantitative treatment limitation with respect to mental health or substance use disorder benefits must be comparable to and applied no more stringently than the processes, strategies, evidentiary standards, or other factors used in applying the limitation with respect to medical surgical benefits. But then they put in a little caveat, except to the extent that recognized clinically appropriate standards of care may permit a difference. So there's a lot of discussion about whether or not actually the carriers will have to, or the plans will have to give equal benefits, but it looks like it's working to that. It appears that the OIG, the government, is looking and saying you have to give the same benefits for both, and that's what parity is about.
Now, to clarify on that, though, Bruce, it's not necessarily the same, or my understanding was, and of course I'm no attorney, but that you might not get the same financial benefit, but you would get the same access to treatment. So that, a procedure, a medical surgical procedure done by a physician might be X, another service done by a physician assistant or another clinical provider on the behavioral health side might be Y, but the idea was to generate a similarity between the access requirements. I thought, the amount of scrutiny you have to go through in order to pursue that service or have the service approved ought to be similar. And, of course, I know there's a great deal of struggle going on with the parity requirements right now. In fact, I've even heard it suggested that the parity requirements might be going a little slow because of the need to have insurance companies on board with the expansion of insurance. Have you ever heard anything like that?
I'm not familiar with the issue as far as the insurance carriers, private corporations coming involved in it. I can only tell you that from reviewing the law, they're grappling with the requirements that plans put on and on providing the benefits and what financial requirements are involved as far as the dates and dates, how many days of benefits are given, whether it's in network, outside of network. There's still a lot of debate going on about it, but under the parity standards, there should be much more coverage in the mental health area.
Mm-hmm. Okay. Question, and this will be the last one for today. Are electronic health records mandatory to participate in Affordable Care Act programs?
The HITECH Act, yes, is requiring that in the future electronic medical records are going to be required. And in fact, that's one of the component parts of the plan that is supposed to bring continuity and ability to communicate and provide and be a cost savings measure. And obviously with Part 2 of the CFR 42, that runs into conflict because when you're dealing with mental health records and privacy, that may cause some turbulence, but there is no doubt about it that we're moving to electronic medical records, and everybody's going to have to start to use them, and I believe they are a requirement. Or if it in a circumstance that other areas in healthcare are required to have the electronic medical records, I believe the same will be in mental health.
Yeah, certainly the Medicare incentive program has much more aggressive timelines on the adoption and use of electronic health records than does the Medicaid segment of the program, which extends right into and I think a little beyond 2020 even. So it's definitely two tracks, but if you're on the more conventional hospital type track, it is the expectation. I'm not sure it's a legal requirement yet, but it's the expectation that that's the standard that's being set, and that you got to get on board with it. Well, with all that said, let me wrap up on the presentation, and let me give you final instructions for getting a certificate of participation. At this time, please click on the green Certificate of Participation button located at the bottom of your screen to generate your certificate for this event. Please be sure to save the certificate to your hard drive first before printing. Please note that you must have viewed today's entire program to qualify for a certificate. If you have any questions or issues about this, please click the Contact Webinar Help Desk button at the bottom of your screen to email the help desk. You can also reach it by writing to webinars@vendome, VENDOME, want to thank Bruce Rosenberg today for an excellent presentation, very, very detailed stuff. Would also like to thank our sponsor, BRM Network, for making today's program possible. And finally, thanks to everyone in our audience for participating today. We hope you'll join us in the future for another behavioral healthcare webinar. That concludes today's presentation. Good afternoon to everyone.